Gail is joining us from NHS BT. She's the Chief Medical Officer and the Director of Clinical Sciences there.
Hello.
And we are going to hear about, and again, I think it's a magnificent thing that we've done in the UK with NHS BT. We're going to hear about the Convalescent Plasma Programme. So thank you very much.
Right. Hi. I will just attempt to get my slides up. Are they showing now?
Yes.
Or are you showing my slides, Catherine?
Yes, we're showing them. Yeah.
You're showing. Okay, I was trying to show them as well. Right. I won't duplicate then. Good afternoon, everyone. As Philip said, I'm Gail Miflin from NHS BT. I was just going to give you a flavour of the Convalescent Plasma Programme that we've been running in NHS BT. It is quite hard to believe it's been going less than 16 weeks and has just been almost an exercise in its startup, because I'm sure most of you are aware that the UK does not have a plasma programme in terms of plasmapheresis. And whilst we collect FFP as a, if you like, a byproduct of our whole blood collection programme, with plasma on a grander scale, you actually need to do it by plasmapheresis, because in a 12-week period you can get 12 times as many units of plasma as you can from a single whole blood donor who's only able to donate every 12 weeks. You could, in theory, actually increase that even more if you increase the number of times people are allowed to donate. So what I'm trying to do today is to give you a bit of a flavour of the programme. Catherine's asked me to speak for 20 minutes, and then I know there's going to be some general discussion a bit later on. So this is my first slide, which just essentially shows what our initial aims were. So we were asked by the Department of Health and Social Care to collect convalescent plasma right at the end of March. And initially our aims were to fit in with what Chris Whitty was saying as Chief Medical Officer, that we will trial any new treatments or existing treatments for new indications in clinical trials. Initially aimed to supply 4,000 units of plasma for these trials, which I'm sure you're now aware are REMAP CAP, convalescent plasma arm, and recovery convalescent plasma arm. But also we knew that if we waited to the results of the trial, that we would not be able to scale to be able to provide thereafter. So we set up a programme with support from the DHSC to be able to identify donors and contact them, to set up a collection programme, to set up the testing, arrange the testing, the logistics and how we distribute them, and then to set up the 2 trials in the treatment arm. Now, as I mentioned, this is entirely new in terms of collection, and we needed to do everything from ordering machines to getting a lot of furloughed staff in. And we really, if I look back, think, although, you know, we thought we knew what we were doing, we only just sort of knew what we were doing. And we were lucky, actually, because red cell demand and platelet demand went down of the order of 30%, 35%, and we didn't therefore need to collect as much blood and platelets. And so we had a little bit of what you might term space within our existing footprint, which we could use to collect some of the convalescent plasma whilst we built in some more capacity. So we've done that, but actually as hospitals have come back on stream, we've had to really use the capacity that we've built. So that was just to give you a bit of a flavour, I think. If you could move on to the next slide, please. I've put in here a little bit of a flavour of what we've done over the first 10 weeks, but it really has been to set up the capability to do that, and it's required things that you wouldn't necessarily think. There's all the usual things, but just freezer space was actually a real pinch point for a long time. And so we've had these massive freezers put in our car parks in Filton and Colindale and Manchester, and I think we've got about 15 of them now in, so we've got a lot of capacity to freeze, but getting those online was actually quite a big issue. And then we've set up, so we normally have, as you know, 24 collection centres around the country, our static centres. We've set up another 9 new areas. Now, some of them are on different floors. So, for example, we've opened the first floor of our West End Donor Centre to enable us to collect convalescent plasma there. But we've opened 3 brand new standalone blood collection places in London, one in Twickenham Rugby Stadium, one in a centre in a community centre down in Bexley Heath. And this week we are opening a big new one in the Westfield Centre in Stratford. So these are things that in themselves would be a relatively remarkable achievement to do in a small amount of time, but we've really had to do this very quickly. Now, additionally, we've had, you may have seen on our website, you can register today. We've had well over 100,000 people register on there. So we've had to set up a lot of call centre capacity to contact everyone. And it just goes on and on. We've now got our in-house testing. We're testing via neutralising antibody, which is slightly different to much of the testing that you will have seen either on the news or have heard about in terms of testing NHS staff, etc. We initially did this with a live virus assay, and we've correlated it with the Euroimmune assay, and are confident that we've now got a surrogate marker for neutralising antibody activity, and so we know what we're collecting from donors. We've got both the REMAP CAP and the recovery trial up and running. We haven't got all the hospitals on board yet, but that's been in itself quite a remarkable amount of work to do that. As of this month, so a couple of weeks ago, we've now got the convalescent plasma arm of the recovery trial as a standalone arm. So those doctors and patients don't need to worry about some of the other treatments as part of the recovery trial. They can simply be randomised to receive convalescent plasma or not. So if we just move on to the next slide. These are some of the media things that we've got going on. I think probably the most relevant thing here is the number of patients in the trial. We've now got 300 patients randomised to both trials, and on the face of that feels quite a low number, I think. We had anticipated that we would recruit faster than this, but the NHS is taken on, as you're all much closer to than I am, a huge amount of work. And we know that about 15% of patients eligible for recovery are electing or being given the choice to go on to the trial. So the numbers are lower, and of course it's fantastic news and that fewer people are going into hospital and becoming ill. So we are seeing about 70 people being randomised on the trials each week, but I do wonder whether with this convalescent plasma arm being a new arm in terms of being able to be randomised just to this, whether we might see the numbers going up a little bit. If you move on, so in terms of kind of where we are on this, we've now collected nearly 15,000, this was last week's figure, so they do go up each week, nearly 15,000 units of convalescent plasma. There was a number of things, though, we didn't, even with our experience, we didn't necessarily see coming. We anticipated that our call conversion rate would be about 30%, so we weren't too far off from that. And what that means is, of the people that we phone up, not everybody will be able to come or be willing to come in and be a donor. And, it is, I take my hat off to people who do it, because they have not until recently been well people, especially the people who've been in hospital. And we are collecting convalescent plasma from 28 days after recovery, which is either discharge from hospital or the end of symptoms. So these people have been through quite a tough time, and some of the stories we're hearing on session are really completely heartbreaking. People have been through a huge amount, as I'm sure you all know. So we anticipated that not everybody we phoned would be able or willing to come in and donate plasma. And some of these are people like the 100,000 I said have donated on our website, but we also, under the Secretary of State COPI notice around information governance, got permission to contact people who had positive results, and so that was facilitated by NHS Digital. So some of these people we have been cold calling, and as I say, they haven't been well. So I guess it's kind of to be expected. What we didn't anticipate was how many people would be deferred even once they had said that they would be willing to donate. 30% is a high deferral rate. We started off north of 40%. We normally anticipate between 20 and 30% for new donors who come in and red cell donations. But I guess, you know, once you look at it, you understand that these people have been ill. There's other reasons why people can't donate. You've, of course, got to be eligible to donate blood because this is a blood component. And you've got to have the right height and weight to be able to have the volume taken off you. So we take around 450 mils of fluid off people. So you do need to have enough volume, and you do need to have veins that can take the procedure because it's done on an apheresis machine. So we did underestimate that, and we did get that wrong, if I'm honest. The other thing that we didn't necessarily anticipate, because we just hadn't done the thinking through, was the spectrum of neutralizing antibody titers in people who come and donate with us. And we had anticipated that in order to do a trial and to see the benefit as quickly as possible, you would want to use either the top quartile or the top third of antibody titers, because that will give you a much more powerful trial and an answer much quicker and benefit in the long run. So we have anticipated that. But I don't think we'd anticipated that around a third of people who come really have got no neutralizing antibodies or very low detectable neutralizing antibodies. So we're finding that, you know, a third of the people that we get into our sessions actually don't provide us with units that we could potentially use in the future. And we anticipate that we will be using the high titer units, and that is, you know, quite clear and obvious. And we're also anticipating that, as you know, there's trials. The biggest one is in the States, where they've given convalescent plasma to 20,000 recipients now, and they weren't measuring neutralizing antibodies prior to giving the units. It's not part of a randomized controlled trial. It's an observed study. And but I know that they are doing the neutralizing antibody tests retrospectively, and we were hoping, and I think we will, get some data on the benefit or otherwise, not only of convalescent plasma overall, but at different titers. And so we have stored all our, if you like, middle third or medium titer units as well. So at the moment we've issued just over 1,000 to hospitals, and as I said, we've just got slightly over 300 people randomised. But we are now getting into an interesting time, because the number of people willing to donate is reducing. I think that's partly as we come off the back of the first wave. I think also as lockdown is easing, people don't see the need to donate as much as possible. And so that is a challenge for us, and we really need to work about how we step up our marketing and our message on that. The other things that we are seeing is the increase in red cell issues and platelet issues. Has meant that there's pressure on our collection spaces, and so capacity to collect. We are constantly having to jiggle on a week by week basis to do that. And actually, most of our staff, a bit like everybody in the hospitals, are exhausted. They have been volunteering to do additional shifts, and they've been doing that for 16 weeks now. So we know that people are tired. So you know, if I look back, I think we were probably a little bit optimistic about what we could collect. So we have collected fewer units than we had hoped to collect at this stage, but we have at least collected 15,000 units to date, and this increases each week as we open our new centres. And as I say, we've got a dedicated centre in Stratford opening next week. We're also looking at how we kind of balance the capacity around the country. So how can we put some more capacity in Leicester perhaps in a few weeks' time, and that kind of thing. Catherine, if you could move to the next slide. So some of this I've touched on already, but actually when you look at the capacity we've built and the number of convalescent plasma units we get out that are high titer, this doesn't include the moderate titer, it is quite a challenge in how much we've lost. So we've really made the decision now to pivot our strategy and to be able to test people first. So we're moving to what we call a sample first. And I think this is demonstrated on the next slide. That if we're able to, we know that we'll have a sort of segmented donor strategy, and that of the units that we're planning to collect, if only a third of them are high titer, we need to be able to not collect the low titer or the negative titer. And if we look at our donors, we know that, as I hope you've heard in the media, if you're a man who's had a test that's positive, you're over 35, and particularly if you've been into hospital, your chances of donating a high titer unit are somewhere between 40 and 50%. But if you're a woman who has had the symptoms, who hasn't been tested and hasn't been hospitalised, the chances of us collecting a high titer unit are 2%, which is really a very low return rate. So what we're planning on doing now is, and I think this is on the next slide again, Catherine, is to move to a segmented approach where if you're a man who's been tested, you go straight to donation, and if you're a woman or that you are untested as a man, we will invite you to have a sample first, and then we will invite back the high titer donors and the high medium titer donors. And we're looking at the moment whether or not we could change our collection interval from 2 units every 2 weeks to 2 units every week if people are willing to donate. We're also starting to look at the drop-off of antibody titers, and we've got our first collection of 4-time and 5-time donors. And actually by over a 2-month period, you do see significant drop-off of antibody levels. And so we don't anticipate that donors will be able to donate for that long a time to give us certainly high titer donations, a little bit longer if we include medium titer donations as well. But it all just does add to the challenge of being able to get people in at a time where they're willing to, they're fit and healthy, but they still have high antibody levels, and to be able to collect as many units as possible. Could you move on to the next slide? I think I've covered quite a lot of this, and I anticipate that many of you will know this extremely well and off the back of your hand, but I just thought it was worth having a slide on the trials that we're running at the moment. So REMAP-CAP, the convalescent plasma arm, has been running since April. This is for people on intensive care unit and are randomised to receive convalescent plasma or not.
Jamila, hello.
Is now joining.
The details of the trial are given in these slides on the REMAP-CAP website if you want to look at this in more detail, but the vast majority of people who are admitted to an intensive care unit are eligible to be randomised there. The recovery trial really is almost all comers into hospital, including children. And again, you're randomised to receive convalescent plasma or not. We were really very keen to get recovery going because intellectually, one would anticipate that the earlier stage of disease would have more of an effect on outcome. We're also now looking, and the protocol is due to go in any day now, at whether or not there may be a third use case in terms of an earlier stage disease, perhaps in patients who are immunocompromised, because we anticipate that this particular group of patients will not respond so well to vaccination, and that at the first signs of disease, there may well be a benefit from convalescent plasma. So that's the thinking in terms of the next trial that we are anticipating setting up. Next slide, please. There have been some really heartening cases, and I know that these are anecdotal, and I know we're wanting to have the results of the trials, but some of the stories we're hearing are really very heartening, and I hope you will have seen some in the hospitals that you work in, but also I hope you will have seen some on the news. But again, there are more details on this. Next slide, Catherine. So I'm just going to spend the last 3 or 4 minutes just talking about what we're discussing with the Department of Health and Social Care. It seems from the early evidence from China that there's potential for use of convalescent plasma, and we are all eagerly awaiting the results from the US. The first paper published the safety outcome, so it is safe and feasible to give people convalescent plasma. I guess to us in transfusion, that's not that surprising to us. And really what we would like to see is the outcome data, and we anticipate that will be coming along sometime in the next month. But certainly there is potential for a potential positive outcome from convalescent plasma. We're also mindful of the possibility of a second wave, and I know the formal planning has now started for that. And interestingly, the numbers in the first wave, if you need to give 2 units, everybody comes into hospital, are vast. The 200,000 units of convalescent plasma is beyond what we can currently supply in this project, which was to supply or to collect 85,000 units of convalescent plasma, which we're on track to do up till October, as long as the donors we're able to still get the donors coming in. But all of this made us think, do we not need to be doing a little more? So we've been in discussion with the Department of Health, and are still in discussion with the Department of Health about continue to collect more and more convalescent plasma. And I think if we do this, it will be an equally big project in itself, because actually what we've built is a system that is not terribly sustainable. We've built it as a very fast startup that sort of cannibalized on much of our capacity within our existing setup. We did employ at least 300 people through furloughed staff from the likes of EasyJet, Superdrug nurses, Virgin, huge numbers of different organisations that we've got furloughed staff from. But of course, some of them are wanting to go back to their day jobs, if you like, now. Some of them will stay with us, but we really need to set up the capacity for a longer term collection for convalescent plasma. Next slide. So in summary, it has been a huge challenge, a real learning opportunity, one might say. It's been exhilarating, it's been very hard work, and it's been extremely challenging. I think, you know, the sorts of things that I've learned is that setting up these things, it's always more difficult than you think. I'm an eternal optimist, but you know, building resilience into a program is challenging. Building in the motivation to do this, taking people with you, working at a different speed of business, working at a different speed of regulatory change has been huge. And of course, there's lots more to do. And the other thing that I think I haven't mentioned, but has been really interesting, is that, as some of you may know, the MHRA subcommittee, Committee on Human Medicines, is looking at the possibility of UK plasma going back into the fractionation supply chain, so potentially to make IVIG or to make a COVID hyperimmune globulin. And that decision is going to be made later on this year, probably early autumn. And some of the things that we're starting to think about were, is that if we have a convalescent plasma business, do we also need to think about plasma for fractionation in there? So there's been lots of discussion to be had, and I think changes around this whole programme for the next 6 months at least. When I come to the RTCs, often I'm asked, what can hospitals do to help? I think, of course, you're doing a fantastic job already. Some of the things we've struggled with over the last couple of probably weeks to months is stock management. We see that our red cell stock requests are 90% of what they were pre-COVID. We know that hospitals aren't working quite how you were working beforehand, as we're all very aware. It's incredibly difficult. Our understanding that much of the transfusion needs are now back up to nearly 100%. The wastage figures sort of confirm this. Is the red cell wastage prior to COVID was around 2.4%, and we're almost back down at those levels again, having had wastage levels of 6% in the meantime. But my understanding is that what you're seeing in the hospitals is that much of the need for transfusion is pretty much back up to what it was before. But stock management makes a big difference to us because it provides space within our systems to be able to collect more convalescent plasma. Of course, we'd love you to randomise as many patients into the recovery trial as you can. I'm sure I'm preaching to the converted in this respect, because I think we'd all like to demonstrate a benefit if we can from something that we can provide in this country. And the other thing is that we're talking a lot about, and to others, about if you have had a positive COVID test, either within your hospital, please do come and donate with us. But from me, a big message is thank you to what you've done so far. And I hope this is what you've been looking for in terms of understanding what we're doing in the Convalescent Plasma Programme. So that is my 20 minutes. Thank you very much.